All right. Okay.
So sorry.
So, no problem. Lah. You just missed my X-rated jokes. Nothing. Okay.
Yes.
So the origin of orthopedics, yeah, is actually from two Greek words: orthos, which means straight, and pedios, which means child, straight child, which was the original description of orthopedic surgery. So it's a branch of general surgery initially in the year 1741. So if anyone asks what is orthopedic surgery, a good way to describe it is a specialty dealing with the preservation and restoration of the musculoskeletal system. So pretty much that's what orthopedics is at the moment. Yeah. So from 1741 until now, currently in Malaysia, we have this number of subspecialties within orthopedics itself. So the first two are what I generally do, which is trauma and pediatric orthopedics, as well as limb lengthening and deformity correction. Everybody does a little bit of all the rest: spine surgery, joint replacement, very common, sports and arthroscopy surgery, hand and microsurgery, orthopedic oncology, which actually deals with bone tumors and soft tissue tumors, and foot and ankle, which, as you may know, deals with foot and ankle problems. Yeah. So it sounds like a simple thing, but if you do study orthopedics, eventually you realize that foot and ankle is one of the most complex sort of subspecialties within orthopedics. So it's not as simple as it looks, actually. But
Because
all
it involves the joint.
it involves the joints, it involves the small bones of the foot, it involves quite a number of biomechanics of the foot and whatnot. You know,
Okay.
so there's a fair bit of there's a fair bit to do in foot and ankle, and it's one of the newer specialties in Malaysia. So in Malaysia, we tend to divide the subspecialties in this way. Whereas if you're in the UK, they tend to divide orthopedics regionally. So you end up being an upper limb surgeon or shoulder surgeon or knee surgeon, and you go more regional in that sense. Whereas here we divide it by topics more or less.
Okay.
Yeah. So it's something a bit different, but this many subspecialties within the field of orthopedics itself.
Yeah, it's good for them to know, because it will also help them define their future.
Sure.
Yeah.
So this is just a brief overview. Each one is as complex as it looks.
Yes.
All right. So introduction, trauma in the acute setting. Okay, this is generally because a little bit on emergency sort of management. Okay, so trauma is actually the commonest cause of death in young people aged 1 to 44 worldwide, especially in the developed world. Large proportion of that's actually a result of motor vehicle accidents. And the management, if you're dealing with trauma or if you're studying about trauma, it actually starts pre-hospital, which is actually at the scene of the trauma itself, the scene of the accident itself, followed by hospital management, triage, primary and secondary survey. Okay, so the initial management is always to manage injuries and prioritize those that are life-threatening first. So you deal with the life-threatening injuries first using the sequence of A, B, C, D, E. I think most of you all have finished medical school. You'll probably be quite familiar with this. So it starts off with a primary survey, which is a quick initial survey to identify life-threatening conditions. And this, someone brought the minion.
Yeah. Mute all.
Except me.
Sure, what's happening? Suddenly there's a lot of echo. Can you mute your mute, please? Okay. It is one of the. Sorry about that.
No problem. All right. So we basically follow the ATLS protocol, which most people will know: A, B, C, D, E. A is airway maintenance with cervical spine protection. B, breathing and ventilation. C is circulation and hemorrhage control. Orthopedics, we tend to deal a lot with the circulation and hemorrhage control part, because patients tend to bleed, and that's where they go into shock and whatnot. They go into hypovolemia. So that is sort of the core of this part of the talk, really. Neurological examination, and of course, exposure of the patient and environment control if they are not in the hospital setting. Secondary survey. So once the primary survey is done, only then the secondary survey is done. So this is a more detailed evaluation of the patient. You have ruled out the life-threatening problems. You have ruled out that he's not going to die on you suddenly. The main airway, breathing, circulation has been is controlled. Then you go for a more detailed approach. Yeah.
Can you kindly mute your speaker, please?
Okay. All right,
Yeah.
so that will involve more of a head-to-toe evaluation, and you can identify the injured, say the injured limb or the injured part of the body, injured system, it must. Okay, and this is the point where you take a proper history and examination of what happens. And then there's some describe it as a tertiary survey, or actually it's just a re-evaluation of the patient's condition after the secondary survey is done. Yeah,
This
so
show is hilarious. This show. What show is
South
this
Park,
again?
South Park. Yeah,
It's damn
I
hilarious.
know.
Sorry,
Okay,
sorry.
so
Okay, so
moving
you
on to that.
reevaluate vital signs and vital functions. Okay, sorry.
So after the secondary survey, you do a re-evaluation to make sure that the patient is stable enough, and then you identify the current problem or based on the secondary survey, and then you have to address that issue as it's done. So this is a standard sort of protocol in the emergency room if you have a trauma patient. Okay, you go to the primary survey and then the secondary survey. Okay, so in orthopedic injuries, hemorrhage is a predominant cause of preventable death. So if they are bleeding and you're able to control that and bring them to a more stable state, you generally tend to prevent them from dying. Okay, so hypotension in a patient, in a trauma patient, accident patient, hypovolemic is generally the cause until proven otherwise. So they're losing blood somewhere. Okay, and how do you identify this? You can look at their level of consciousness. Of course, if they have a concurrent head injury, it's difficult. But if they're suddenly getting drowsy and whatnot, then you have to rule out hypovolemia as a cause as well. Skin color, if they're pale, if their pulses are rapid and steady, and if obviously there's an external bleed, then it's continuously bleeding, then it has to be identified and controlled. Yeah, so hypotension is one of the parts that we have to address in treating a trauma patient. General management, this is by no means a rule, but this is generally what people do. Of course, if there is a bleed, control the bleed, control the hemorrhage, make sure it's pressured over the bleeding area, splinted. Fractures have to be splinted. If there's an obvious fracture, the limb looks deformed, they have to be splinted temporarily. That will actually prevent further bleeding at some point when you splint it. Of course, blood group cross match, fairly basic stuff. So set up large bore cannulas. And just as a quick guide, if you actually realize that if you have a femur fracture, you can lose up to 1 liter of blood, even in a closed femur fracture, which means there's no open wound, but that amount of blood can actually be lost. If you have a pelvic fracture, and called the open book, which is the most severe type of pelvic fracture, up to 3 liters of blood can be lost, which is almost similar to having an intra-abdominal injury. So bone musculoskeletal injuries, there's a high tendency, especially in high impact, high energy trauma, there's always a chance of losing a significant amount of blood, right?
Even
And
if it's a close fracture.
yeah, because there's a lot of, the blood supply to the bone is quite abundant. So you have
I
the
see.
periosteal and medullary supply, especially to the long bones like the femur, the bigger ones. You know, like rib fracture, you're not going to lose so much, but the bigger long bones, you tend to do that. Yeah. So what you have to do at that stage, if you are you're worried about the circulation, the C part of the ABCDE, you have to assess the stage the patient may be going into shock. Yeah. This is just a guide. I think it's in every medical textbook as well, to stage shock as it is hemorrhagic shock. Yes, it's got stages 1 to 4, various parameters for each stage. I don't think we're going to memorize it or go through each one of it now, but in general, stage 1 is okay, stage 4 is bad. Yeah. And it comes to the management
Can we
of
go
it.
back to the previous?
Yeah, sure.
I just want to tell them that the heart rate, the blood pressure, and the conscious status and respiratory rate are very good indicators clinically of how the patient is. Okay. So when you look at this patient, pallor is also one of them.
Right.
Sometimes you just see them being very pale, and you must act on it.
Right.
Okay, so you don't have to memorize it like which is which, but these are the things that you look for in the emergency. Okay.
Right. Yeah, so all these parameters are actually closely monitored when the patient comes into the emergency room. So each of that, of course, the pulse rate, blood pressure, respiratory rate, urine output, all that is generally well documented once they come in. So you just have to be aware that if they are falling into one of these categories, they could be in a state of shock, hemorrhagic shock, not cultural shock, I think. All right, so general guideline. if they're hypotensive and tachycardic, run crystal. This is a very, very brief general kind of thing. Yeah, it's not a rule. Okay, if they're not responsive after 2 pints, generally you will need blood. So it's not just the crystalloids. Another way of remembering, of course, if urgent blood is needed, you have group O negative blood, which is the universal donor. And if it's stage 1 or 2 shock, generally they respond to just the crystalloids. 3 and 4, you will need blood as well. It's just a sort of a guide, yeah? But just remember that the aim is always to stop the bleeding whenever possible. If there's an external hemorrhage, if there's a fracture, splinting the fracture actually helps. And the second concept is actually replace whatever blood was lost. Okay. Yeah, so generally, if you're going to deal with the circulation part of the ABCD, this is just a guide in a way. Okay. So yeah, then you get the bill. Like, so suppose not all hospitals lah. If you're in
only your hospitals lah, maybe.
Klang Valley, a lot of hospitals like this. No names mentioned. Okay. Anyway, so we go to the next concept. So this is a different concept. It's called damage control orthopedics. All right. So it's not many people will know this. So this is in polytrauma patients. So it's a strategy that focuses on managing and stabilizing major orthopedic injuries in polytrauma patients who are unstable, who are physiologically in a stressed physiological situation. Okay. Previously, back in the 1960s up to the 1980s, the concept of early total care was used, which means that if a patient has multiple fractures, everything was treated as early as possible. Fix everything, and the patient will survive, or they do better. But eventually, we realized that wasn't the case. And then they started figuring out why were people doing so, poorly, despite being treated, urgently, immediately for everything. So what was found is that patients are actually at risk of developing ARDS, acute respiratory distress syndrome, and multi-organ system failure during an acute inflammatory window, which actually occurs from the period of the 2nd to 5th day. So what happens is, I'll explain a bit more here. So the first graph on the left shows a systemic response to injury. So we have injury happening here. This is known as the SIRS, is systemic inflammatory response syndrome. And then you have all your inflammatory markers going up, and then they come back down. So at day 2 to 5, which is somewhere here, they tend to be at their peak. The inflammatory markers are at maximum. Not when they are first injured. It increases as the days progress. The bottom part of the graph is actually the compensatory mechanism, yeah? Compensatory anti-inflammatory response syndrome. So they should balance out each other, and the patient does well and achieve homeostasis. So what happens is the first hit is actually at the trauma, yeah? So we're going to the next graph. Trauma is what is called the first hit. Happens here, all your inflammatory markers go up. So technically it should come back down now and resolve. But the second hit occurs if you do a prolonged or difficult surgery. So you increase the inflammatory markers again, and then they go off the charts. And then they end up with multi-organ dysfunctional syndrome, MODS as they call it. Okay, and eventually death actually. So the idea of damage control orthopedics is avoid the second hit. Avoid operating at a time when they're going to do worse.
Can I ask a question here?
Yeah.
Does this apply to patients who have polytrauma only?
Yes. If they have multiple traumas, only then their inflammatory markers go to. If patient has a one single bone fracture, like there's a tibia fracture or finger fracture or something, it's not going to go into this. This only applies to polytrauma patients where either they have multiple fractures or they have multiple organs which are injured, including abdominal, chest injury, head injury, cervical injury. So it's in patients who are much worse than just a basic sort of one bone fracture guys. Yeah, so these are polytrauma patients, but this is a concept that has started to gain popularity from 2000 onwards actually this year. Yeah, if you're sitting for masters, they like to ask this question as well. Whoever's doing orthopedic masters. Yeah. All right. So what are the potentially life-threatening injuries that should be treated during this period? Unstable pelvic fractures, compartment syndromes, fractures where there's vessel damage, vascular injuries, dislocations, of course, traumatic amputations, unstable spine fractures, cauda equina, which is compression of the spinal cord, and open fractures. So these are the exception to the rule. So these are the conditions that will need urgent treatment. You cannot wait after day 5 and then go in and, fix an unstable spine fracture. So these need to be addressed as soon as possible, as early as possible. Yeah, so this is the first, the problem when it comes to polytrauma patients. When do you actually do the surgery? Do you do it on day 1, day 5, or whatnot? Yeah. So what they've suggested is initial stabilization is done. So if patient has an open fracture of 2 long bones or 3 long bones, that means he has 2 femur fractures and a tibia fracture. The idea is to not just leave him until day 5 so that his inflammatory markers come down. No, the idea is to do minimal surgery, which would be what is required: debriding the bone, stabilizing the fracture using maybe an external fixator, a temporary stabilization. Once he has passed that phase, only then consider a definitive fixation. All right. So for example, a pelvic fracture, if the pelvic fracture is unstable, you have to stabilize it initially, probably commonly with an external fixator. A week later, only then you proceed with the second surgery where you actually definitively fix the fracture using more conventional methods. Yeah. So same goes for femur fractures and tibia fractures. You delay the definitive treatment. The initial treatment is still done. The initial surgery is still done.
Sorry, Roshan, can you go back the 2 slides before, please? Okay, no, this the next slide. Okay, this one. You said that only these injuries should be treated as soon as possible.
From orthopedic point of view.
Okay, and as soon as possible also means that you should wait after 5 days?
No, not at all. So these are the things you don't wait for.
Okay,
you still need to treat them, but you treat them with the minimal surgery as minimal as possible. So you don't spend 4 hours trying to reduce the fracture and put in a nail. You do a quick surgery, you stabilize, you debride, clean the wound, and you stabilize it with an external fixator, a temporary fixation, a splint, whatever it is, quick surgery. So you don't spend too much time. The second hit usually happens if you have a prolonged surgery with even more bleeding and even more soft tissue damage as you go along. So it's doctor caused problem. So these are urgent conditions that need to be treated, but with minimal sort of surgery.
Okay.
Yeah. Okay, so we'll go through that. Okay, so this is just another confusing diagram to show what happens. But again, the main idea is to avoid the second hit. Yeah. So for this is pretty much all the participants right now. Okay, so I can hear crickets also.
No, I'm clear. I'm so clear that tomorrow I'll be an orthopedic surgeon.
Okay, all right. So just to summarize again, in polytrauma patients, inflammatory mediators are released due to the trauma. We prevent the second hit by doing a long or prolonged surgery, but you do the minimal limb and life-saving procedures. Definitive management always occurs later, generally about a week later. So just that's as basic as I can put it for polytrauma. Yeah, and the concept of damage control orthopedics.
This is a very interesting concept, and I think I believe in it.
Yeah. It does make sense. It's not just an exam topic. Actually.
That's right.
It is being practiced.
Yes. And it's something I knew, something I learned.
Sure. All right, so I just run through 1 or 2 emergencies. Pelvic fractures are one of the emergencies I mentioned. So the pelvic ring usually is only injured in high impact or high energy trauma. Okay, you don't really get a major pelvic injury by falling down, 1 flight of stairs or sitting down in the wrong position and all that. Okay, the problem is there's extensive vascular supply around the pelvis. And what happens if you get an unstable pelvic fracture? You tend to damage the venous system. And the venous system is very hard to control once it starts bleeding. The arteries are easier. Now the veins are small. You can't go in and operate actually. So what needs to be done is usually packing it or compressing it so that you don't get further bleeding. So hemodynamically become very unstable with pelvic fractures. Okay. So normally what happens, you reduce the internal hemorrhage by either a pelvic clamp in the emergency room, or sometimes they have like a cloth just to pelvic harness kind of thing, or an external fixator, which we commonly use. Yeah. And again, the definitive fixation only happens much later. So initially patient will be on this kind of external fixator just to stabilize the fracture and to reduce the chance of hemorrhage. Okay, so pelvic fractures are a bit of an urgent thing to address, especially if they are the more complex and how do you say, unstable type. Another emergency in orthopedics is open fractures. So open fractures just means any fracture that's associated with a wound. So there's actually contact between the external environment and the bone. And this leads to a high risk of infection and eventually osteomyelitis of the bone. So osteomyelitis is very, very difficult to treat. Once it sets in, it's generally there for life. It's very, very difficult to manage. So open fractures are generally treated as an emergency. The wound needs to be debrided early and stabilized as fast as possible. Yeah. So if you have a one bone open fracture, it's not considered DCO or polytrauma. You can do a definitive fixation if you want. Okay. If there are multiple bones, then you worry about the inflammatory markers and all that. Just to reiterate. Okay. So always when you have an open fracture, always assess the limb, especially for any neurovascular damage. Open fractures indicate high energy trauma, indicating high chance of nerve and vessel damage. So you have to assess whether the distal circulation is intact, if they can at least move the toes or have lost sensation somewhere. Okay, management wise, always start with IV antibiotics, tetanus, irrigate the wound thoroughly in the ED, apply sterile dressing, and stabilize the fracture with a splint. So you don't need to get perfect alignment, but you need the leg to be pointing in the right direction at least, and splint them. Once you've done the splinting, always reassess the neurovascular status, because sometimes when the patient first comes in with an open fracture or the limb pointing in the wrong direction, and you feel that the distal pulse and dorsalis pedis is not there, is absent. But once you stabilize the fracture, you sort of pull the leg in the right direction. The vessel generally is not torn off, it's probably just kinked. So the circulation will actually return. So always reassess the neurovascular status often in these type of patients. Subsequently, patient will need a debridement, washout, and stabilization, commonly with an external fixator. Sometimes a repeat debridement is indicated. However, whenever you do a debridement, for those doing orthopedics, always ensure that you have enough soft tissue coverage. There's nothing worse than having the bone exposed to the environment after debridement, because the bone and the environment, if it's an open fracture, if you have debrided and the bone is exposed, the bone will eventually die off. The bone needs soft tissue cover to survive. So make sure there's enough soft tissue cover most of the time for open fractures. Yeah. Okay.
Can I ask a question, please?
Yeah.
Okay, when you see, when you look for neurovascular status after you have done the splinting and everything, okay, what if there is neurovascular status compromise? What can you do about it?
Okay, so in that case, again, you have to remember that the common causes for neurovascular compromise in these type of fractures is generally kinking of the artery or sort of a internal, like a thrombus kind of thing. It's not very, very rare. It's a complete transection of the artery. But if the circulation does not return after splinting, then the patient, if you're in a center that can, provide you with angio or CT angio is useful. If you're in a center that doesn't have all that, then exploration during surgery would be the answer. So you actually, while debriding, you have to identify where the bleeding or whether the vessels are cut off and whatnot, if at all possible. But depends on your resources. We have, something as good as a CT, then you can, you're a bit safer. But otherwise, you have to just debride, explore, and see if there's any vascular compromise. Usually in an open fracture like that, if there's a wound like the picture I showed, then the injury will be around that area. It mean high chance that if there's a vessel damage, it's a vessel around that area. It's not something away, too far away from the wound. So generally extend the wound and explore if needed in these kind of cases. Yeah. Okay, so the next is just principles of fracture management, non-acute setting now. We're away from the emergency room. So the primary aim of any fracture treatment is to attain bone union without any deformity. So when you're thinking of long bones, things like the femur, you have to restore the length, the alignment, which is basically looking at the bone in AP and lateral views, the rotation of the bone, and if the fracture involves a joint surface, such as the knee joint and whatnot, you actually need a good anatomical reduction. Because if you don't get that, you tend to end up with a bit of imbalance within the joint, and that leads to early degenerative changes. Yeah, so these are generally the four concepts in bone union. You need to restore length, alignment, rotation, and anatomical reduction at the joint surface. And the aim at the end of the day is restore function of the injured limb. So the patient, once everything is done, has to be back to his pre-morbid state. If he was, healthy person playing badminton before, he should be back to that once everything is settled. Yeah. So how do you approach someone who has a fracture? As with everything in medicine, you start with the history. Okay. So history is important. Date, time, place of the incident, whatever incident that happened, nature of the accident, magnitude of the force, very important. Whether it was a low impact, I just fell off my bicycle, or I was hit by a train. So two different, impacts there. Mechanism of injury in orthopedic is very, very important, and later kind of explain why. So mechanism meaning if the patient can remember how he actually fell. Did he fall directly on his shoulder? Did he fall on an outstretched hand? Did he kneel down and fall? Did he fall in a sitting position? The mechanism of injury actually tells you in a way what type of fracture you're going to get, and generally where the fracture may be. So if you know the mechanism, you kind of have an idea what the fracture would be. And that helps in terms of managing the fracture. So if you have a fall on outstretched hand, distal radius fracture with a certain type of displacement, and you know to reduce that fracture, you actually have to reverse the mechanism of injury. Oh. You go reverse and then you can reduce the fracture. Yeah. It's quite important in ankle fractures. Distal radius not so. Ankle fractures have a certain, a bit complex that one. We won't really go into that, but there's a certain like a mechanism to that. Okay, so anything else? Precipitating factors, you have to understand if there was any underlying medical condition. Patient slipped and fell in the bathroom, but did he have a stroke before that, or did he lose consciousness and whatnot? And then the common things like pain, the site severity, radiation, is the pain radiating anywhere? Functional loss, always check for, they can't move obviously in a fracture, but also things like numbness, paresthesia, whether there's any compression or compromise of the nerve function. Is the limb going blue? Is it, turning color? So there's a compromise in the vascular situation as well. So history is fairly important. Physical examination, again, pain, is there any bone tenderness, joint line tenderness, is highly sensitive and specific for fractures. So if you really can't read any x-rays, you really don't know what you're looking at, bone tenderness will give you a clue as to whether there is a fracture or not. If there's pain when you palpate the bone, high chance there's a fracture. Okay. Deformity, obviously, if there's a fracture, if there's some deformity, it'll be fairly obvious just on inspection. Swelling is a fairly consistent feature in most fractures. So if you have a fracture of the calcaneum of the heel, the swelling can be quite immense. So swelling is a consistent feature in most fractures. If you're still unsure on examining, I don't know how to read x-rays properly. If there's pain, there's bony tenderness, and there's swelling, it's generally of like fracture until proven otherwise. Okay, loss of function, meaning which obviously they cannot move the arm or the limb. Neurovascular status, again, I keep stressing on that because that is one of the main problems when it comes to fractures. It's not just the bone, but the soft tissue surrounding that and the neurovascular status have to be addressed most of the time. Investigations, okay, you can see this one. X-rays, you have to take 2 views, yeah? So the general rule of 2 is this. Why do you take 2 X-rays? Because of pictures like this. Yeah, so you can see that there's a difference. If you take a lateral view, you might interpret things differently. If you take an AP and lateral, then you get a clearer picture. So the same goes for fractures. All right. The other rule of 2 means that you have to include in a long bone the joint above and the joint below. That generally helps. And the other 2 rules are actually that if applies generally to pediatric ortho, because pediatric ortho, the interpretation of X-rays is a lot more difficult. So if sometimes you're not sure if there's a fracture, you compare it with a contralateral limb. So you take 2 X-rays. So you take the right side is injured, but you compare with the left just to make sure that it looks about the same. The other rule of 2 means that you take an X-ray at 2 different periods of time. So you're still not sure if there's a fracture. You've taken both sides. You've taken both views. You're still not sure. So you take a repeat X-ray in a couple of weeks, in 2 weeks' time. If you see some callus forming around that area, you see a fracture line appearing, then you know there was a fracture. So it's more retrospective. So that's generally the rule of 2 when it comes to X-rays. Other modalities, if you're lucky enough to have, of course, things like CT scan, MRI scans, ultrasound scans, but it depends on which hospital you're working in and what are the resources there. X-rays tell you a lot, but more importantly, the physical examination tells you more. Okay, so if you can take
Oh,
a history and examine the patient properly, you can at least identify there is a fracture. What type of fracture? Of course, you would need some sort of imaging to do it, but at least you can diagnose a fracture. If you're really in a small clinic kesihatan and you're not sure, you just splint it and send it to an orthopedic unit, you know. So at least you have an idea there. So it's good to have this. X-rays generally most people have, but the rest of it, if you can't have it, you have to just be, practice reading X-rays, I suppose.
how does one practice the reading X-rays? Huh?
I read more and more X-rays, see more patients, as we tell most of our students.
Because
Yeah,
it's
it's very hard.
it's
Yeah,
difficult to train the eye to see,
yeah.
and yeah.
It's like me. I still cannot read ECG. How do you train the reading CGs? Yeah. So
Yes, yes.
it's the
It's all
same. Yeah.
about training, yes.
Yeah. So you see more X-rays and you see different types of X-rays. It varies because if you're dealing with adults, it's a little easier. If you're dealing with children, the X-rays are even more complex because they change as they get older. So that's even
Okay.
more of a bit of a strain sometimes. You know.
Can I just make a point here?
Sure.
I think to be a good doctor, you need to make conscious decision. Means before the X-ray report comes out, try to read it and try to make a decision of what it is. Then when the report comes back and you say, oh, I guessed it right. Then if that practice goes on, you will become a better doctor.
And eventually, you may realize that don't rely on the reports too much. You have to be good at interpreting it yourself sometimes because the
Okay.
radiologists only see the images, they actually don't see the patient, so it makes a difference. So
Okay.
again, the
Maybe
physical
it's different
examination
from you.
plays a part.
Okay,
All
we
right,
go on.
so management of fractures, simple. To get a fracture to unite, the bone ends have to be brought together, which is basically reduction, reduce the fracture, uh, immobilize it, keep it together, and rehabilitate to full function. So it's basically reduce, hold, and move. Yeah, three concepts in management of a fracture. If you're sitting for orthopedic masters and they ask you how to treat a fracture, this is how you pass. You reduce, hold, and move, and you pass the exam. That's it. Simple. Seriously.
Okay.
Okay, so the concept of reducing and holding is like this. So you can reduce the fracture open surgically. That means you make an incision, hold the bone, and put it together. Or you can do it closed as a close manipulation and reduction, where you pull the limb and sort of bring it back into alignment. How do you hold it? You can hold it internally again using any sort of metal implants and plates and wires and screws, or you can hold it externally either with splints or with a POP and whatnot. So the concept is the same. You always reduce. You can reduce either open or close. You always hold either internal or external fixation. Okay, so that is as basic as it gets for fracture management. And this is a thing called the fracture quartet, is how you treat it. So there are 4 different things: move, hold, speed, and safety. All right, all of which we have to address when actually dealing with a fracture. So different methods of treatment have different plus points in 1 or 4 of these things. We'll go through it and go through the examples later. Okay, so but just remember there is such a thing as a fracture quartet. Okay, casting. Yeah, I was asked to do a little bit on POP casting. So this is how not to apply a cast for most people. Okay, if you do, then yeah, tak apalah. But yeah, so casting in itself is a bit of an art, so you need to be a little bit more smart how to do it. Okay, plaster of Paris, a little bit of background on that. This is what it is. POP bandage consists of that. When you add water, the calcium sulfate takes up the water of crystallizing. So basically it's this exothermic reaction, and this very complex diagram shows how it's done. Okay, so plaster plus water equals to the POP generally. Okay, if you're sitting for exams, they tend to ask what this what do you call it, equation is lah. But other than that, you don't really have to remember. If you're an orthopedic surgeon, nobody want to remember these numbers all. Yeah, but generally the concept is add water, it will become harder. Okay, so how to apply a cast? This is a nice way. This is not the nice way. Okay, try not to do something like this. Is what was done probably back in the day, but not now lah. Huh? All right. Okay. So what do you do when you have a patient who requires a cast? First thing is hand hygiene. Don't forget you have to wash your hands now. Everyone does that, so now it's not an issue anymore. Okay. So wash your hands. Make sure they're dry. Dry the patient's limb as well, because if the patient's limb is wet and sweaty and whatnot, and you apply a cast which is hot in its own right with all this padding, it tends to get very uncomfortable for them. So you have to make sure it's dry before you apply. You apply what is known as a stocking net first, which is basically a stocking net, and then a soft cotton bandage around the limb. Okay. If you're going over bony prominences, you tend to add a little bit more padding in that area so that the cast does not press on it most of the time. Because you keep these people on cast for a long time, 6 weeks, 3 months, you won't know if they develop pressure sores over these areas. Okay. Before you apply the POP, keep the limb in the required position. So like in this case, the elbow is in about 90 degrees before the cast is applied. Yeah, so the elbow is flexed at 90 because this is the position we want. If I apply the cast in the arm straight and then later bend it into 19 degrees, I will get kinking of the POP in this area, in the cubital fossa. And that actually can cause, again, skin abrasions and problem to the wound. I've actually seen a lot of problems like that if they are manipulated too much after applying the cast. So once you apply the stocking net and the cotton bandage, then you apply the cast as such. You roll the fiberglass cast or the POP cast, whichever you're using, without causing too much tension over it. So you're just sort of just rolling it over. You're not actually pulling it and putting it across, okay? Because that tightens it up too much. The other thing is avoid leaving sharp edges, sharp surfaces, especially for the fiberglass cast. Mold it into the required shape. If you're doing a forearm fracture, it needs to be molded in the shape of a banana apparently. But various parts of the body, you mold it as required. Ensure the cast is not too tight. Fingers should not be turning pale and blue when you're doing that. They should be able to move their fingers once you've applied the cast. They should be able to hold the pen if you're doing this type of an upper limb cast. If they can't, that means you've not applied it properly. And please ensure there's no sensory deficit after you've applied the cast so that you know that you haven't put it on too tight. Yeah. So these are just things that a few sort of pointers into cast application, nothing much more. Yeah? Okay, so sort of pointers into cast application. I'm hearing myself again. Okay.
I hope that you please kindly unmute yourself so that we don't hear your background. Okay.
Okay. Okay, so we're back to this fracture quartet, what it means by move, hold, safety, and speed. Okay, so this is how you treat a fracture and how they play a part in it. I'll come back to that in a minute again. So these are common injuries that we see. Okay, clavicle fractures, the collarbone. Mechanism, usually patient falls on an outstretched hand or direct impact to the shoulder, falling off bicycle, commonly I've seen that. The outer fragment of the is pulled down by the weight of the arm, and the inner fragment of the clavicle is actually pulled by the sternomastoid muscle. So you get the displacement of the fracture. Okay. Common symptoms: pain, swelling, deformity, and inability to move the shoulder. So fairly obvious fracture. Okay. Options for treatment: not all of them need to be treated with the surgery. Okay. If you use an arm sling, it's generally good enough if the displacement is not much. Okay. Using an arm sling is safe. The speed of healing is good. It heals in the right time. However, it does not hold as good as an internal fixation or surgery. Okay, so that's the quartet. The problem with the quartet for an arm sling is holding. Holding is poor, the other two are strong.
Okay, I see it coming along.
Yeah, so if you do an internal fixation, which is a wrong spelling there, but sorry. Internal fixation, you hold it well. You can move the arm earlier because the fracture is more stable. So the speed is good. However, it's not so safe because you're actually opening up the skin and you're putting in a metal implant and you've got risk of infection and everything, general anesthesia risk of operation, post-op, all that nonsense. Yeah, so safety-wise, maybe not so much, but it actually helps the other part of the quartet. Okay, so this is an example of a patient I had. Mid-shaft clavicle fracture. This girl was a backseat passenger in the car. She was wearing the seatbelt and somehow that's where the fracture happened. Okay, so you can see that this is one fragment here. You can see the pointer, right?
Yes.
And this other fragment is actually up here. So it's
this pointer is your pointer or?
Yeah, it's just my arrow.
Okay.
Okay. So the fragments are too far apart, yeah?
Yeah.
One end is here and the other end is down here. So if you were to treat this conservatively with an arm sling, it's probably almost impossible, okay? The new bone's not going to form anywhere in between such a big gap. So for this, we had to go for an internal fixation. So we managed to bring the fragment down and put a plate across. She healed pretty well in about 6 to 8 weeks and she's back to function. Okay, so some cases you have to do surgery, there's no choice. Some of them, if the fracture is just next to each other, they didn't displace much, arm sling, any sort of immobilization is generally a good option. Okay, shoulder dislocation, another common injury that we see. the commonness is for the shoulder to dislocate anteriorly. So the shoulder joint moves forward. Yeah. Again, the mechanism is usually fall on hand. The humerus is actually driven forward and it avulses the labrum of the joint and the anterior capsule generally gets torn. So this is what happens when you tear your, when you dislocate your shoulder. Very, very clinical diagnosis. They come in with a typical pain of the shoulder. They cannot move. And the lateral outline of the shoulder is actually reduced. So your deltoid muscle contour is actually flattened. Okay. And they cannot move the arm. They generally just hold it in one position. Yeah. Always check for axillary nerve paresthesia because that can be damaged in anterior dislocation of the shoulder. Management wise, as with all dislocations, you have to do a close reduction. Most commonly, we do it in the emergency room under sedation. If it fails, then they may need general anesthesia. And then you try to do a close manipulation and reduction and bring it back into place. If that still fails, then you need to do an open reduction of the shoulder and reduce it, okay? Because what happens is the shoulder joint can dislocate, right? But the soft tissue around there is also torn. And sometimes what happens is the soft tissue will get in the way of you trying to push it back in. So close reduction may not be possible. So you need to actually open the shoulder joint and stabilize it. Not so common, but it happens as well. Yeah. So always the first management will be a close sort of reduction under sedation, if not under general anesthesia. But always remember, if you're doing a close reduction, check for axillary nerve injury because it's one of the common nerves that can be injured in a.
You check for that?
Sorry?
How do you check for axillary?
So you check for the regimental badge, C4 area, the C4 dermatome. That is generally the supply of the axillary nerve. So you look for sensory loss over that area. It's difficult to ask them to sort of move the shoulder and lift it because they've just dislocated. They're not going to do that. Okay. So you have to go for the sensory component of the axillary nerve at the initial setting. Okay. Okay. So this is an example of a shoulder dislocation. The shoulder is down here, far away. And the glenoid is here, yeah? This is where it's supposed to be. So in the second picture, you can see the humerus has come into place. Yeah, so this was done just as a close reduction. And patient didn't have, thankfully, any nerve palsy. Okay, so this was done under sedation here. Another common fracture, humerus fracture, the shaft, fall on outstretched hand again, exerts a bending force as they fall, and it's common to get a spiral type of fracture. So if you look at the fracture later, it looks more spiral, okay? Clinically, of course, pain and deformity, very obvious sometimes, reduced range of motion. In this case, check for radial nerve palsy because the radial nerve passes through the mid shaft of the humerus. So this is the nerve that would commonly get injured in a humerus shaft fracture. Again, options are there. You can do what is known as a U-slap or more, Changi name coaptation splint, which is the same thing. So if you use that, it's basically a POP cast kind of thing. Safe, heals about the same, but you can't move them early and it doesn't hold the fracture as well. If you do an internal fixation, you can start moving early. You hold the fracture very well. The speed of healing is about good. However, again, there's a risk of surgery and a risk of damage to the radial nerve if you do, sort of clumsy surgery as well. So iatrogenic injuries in humerus fractures are well documented actually. Iatrogenic radial nerve injury, yeah. This is an example. So it's a spiral type of fracture. Okay. This boy. Here I put an intramedullary nail to hold the fracture in place. Yeah, so this one, conservative would have been okay if you put a cast on the outside, but what happens is then you can't move him so much. He has to keep the arm in a very uncomfortable cast for a long time. So if you put a internal fixation such as this, you can start mobilizing and getting the shoulder joint moving a lot earlier. Okay, distal radius, very common. Old ladies fall and fracture the wrist. Young people fall in motor vehicle accidents and also fracture the wrist. Pain, swelling, deformity is fairly common and common symptom. Close reduction and a cast, you can hold safely. However, you cannot move them early. If you do internal fixation, which is open reduction and plating commonly, fairly good. You can hold, move, and get them back to function fast. However, again, there's a risk of surgery. Okay, so this distal radius, the fracture is here. I don't know if the arrow is pointing to the right spot. So this is actually the distal radius, which should be up here somewhere. Yeah. So after fixation, it's in the right place. Okay. So some of you may ask, why is this fixed? Why not we just, pull and put him on a cast? You can pull it back, put a cast, probably okay, because it's extra articular. It's not involving the joint so much. Doesn't look that bad. The problem with this patient is he also had a femur fracture. So for his rehabilitation, he's got an upper limb and a lower limb fracture. So he's not going to be able to use crutches. He's probably wheelchair bound.
Oh,
So if you're going to use a cast for the upper limb and then do surgery for the lower limb, the recovery, the rehab and all is a lot more complex. So it was decided that we fix both in this case. So if you get a patient as such as this, your options are both. You can actually do a close reduction if it's just a distal radius fracture. He doesn't need to go for surgery. You can do it in the emergency room if you're really good. Put a cast, he should heal. But if he has a femur fracture, then the decision has to be made differently. So when you're dealing with fractures, you actually have to take it patient at a time. So each patient will present differently with different problems, with different type of patterns, and you have to think of their rehab post, for recovery, their rehabilitation, their mobility after that, and their function at home, how they're going to cope and all as well in your decision making on what is the best option. Yeah, so sometimes there's no 100% answer, or this one must operate, or this one you must put a cast. It can always go both ways, but it based it on what the patient's need is actually most of the time, not the surgeon's preferred method. Okay. All right, femoral neck fractures are common in the older patients. These are low impact osteoporotic fractures. You always get a lot of people slip and fall in the bathroom, a very common sort of injury. Clinically, they're unable to weight bear. The limb will look shorter than the other side, and they're unable to move the hip joint. Yeah. In these cases, if you have an elderly lady who fell, the main aim is to get them back walking, mobile as soon as possible. So in these cases, there's no option really to put them on a splint or traction for 6 weeks and then slowly mobilize them. The best option is always surgery. Okay, so they will invariably need it. Of course, those who are completely moribund and very poor sort of ASA5 fellas and really not fit for surgery, then we have no choice lah. You have to think of some alternative, but in general, most of these end up with surgery. Yeah. So this is a femoral neck fracture. There's actually a line across there. And this is a hemiarthroplasty where half the hip joint is replaced. The acetabulum is not. So if you replace the acetabulum and the femoral component, then it's a total hip replacement. If you replace half of it, it's a hemi hip replacement, hemiarthroplasty. Yeah, so we didn't replace the acetabulum, only the femoral component to it. But this, in these old ladies, this is generally most of the type of surgery done. Shaft fractures, femoral shaft fractures, also very common. High energy trauma, a lot of motorbikes accident have femur fractures. Unable to weight bear, pain and deformity. I think clinically quite obvious that they have a femur fracture. If you miss it, it's ridiculous. Surgical treatment most of the time. Okay, in adults, it's very hard to put a cast for femur fracture. It's almost impossible. Okay, so it goes. The common debate is whether you use nails or plates to fix it. However, the main aim for any fixation would be early mobilization. Get the patient up and moving as soon as possible, prevent knee stiffness, and prevent muscle wasting. So whichever method of treatment you use, the aim is to get them mobilizing early. Okay, so femoral shaft, this is a displaced fracture. All of them displaced, none of them will stay in place. And this was also treated with the intramedullary nail, similar to the humerus earlier. Tibial shaft fractures, I actually don't have one on my own here. It's usually, again, similar to femurs. It's due to high impact. Diagnosis is quite simple, pain, swelling, deformity. Rule out open fractures because tibia is a subcutaneous bone. Very easy to get an open fracture in tibia. Options are there. You can use a cast for some cases. You can use an internal fixation in some cases, depending on the type of fracture, the type of patient, and also think of their rehabilitation thereafter. So this is one that was treated surgically, not by me. This is just an image I found. Yeah, but again, using an intramedullary type of nail. Sorry. And this is an ankle fracture. So injuries around the ankle are surprisingly common. Okay, so they can range from simple soft tissue injuries, which are sprains, very, very common. Usually they twist their ankle while playing some sort of game or just stumble around. And you can get fractures or one or both of the malleolus, which invariably makes the joint unstable. Mechanism is usually a twisting injury of the ankle with an axial load. So you just imagine yourself spraining your ankle. You step on it and you twist the ankle. Yeah. Clinically, in ankle injuries, right, swelling is a very predominant feature. You tend to get a fair amount of swelling in ankle injuries, whether it's soft tissue or bony. So, of course, pain and deformity is quite common. Again, depending on the type of fractures, if it's undisplaced, you can even treat them with a cast. More complex injuries may need internal fixation. However, again, the goal for any treatment will be early mobilization to prevent joint stiffness. If you put someone on a cast for 8 weeks to 3 months, the ankle joint becomes extremely stiff. So rehabilitation after is a lot of difficulty. So if you fix them internally, use surgical methods to fix them, generally you can start mobilizing the ankle a lot faster. Okay, this is one case I had, which is horrible injury. So he's had what is known as a fracture dislocation of the ankle. So both lateral malleolus, medial malleolus fracture, and the whole joint is disrupted. Yeah. So this needed to be reconstructed back into a proper looking ankle at the end of the day. So these kind of things, you really cannot go conservative and whatnot. Okay, it's quite a significant injury.
This is this kind of metal plating and screws and nails or whatnot. They are all mix and match, is it? Is the decision
No, they come in a
made
set.
by? Oh, they come in a set. Okay.
Yeah, I mean, like if I order the lateral fibula plate or whatnot, they have specific for specific areas.
I see.
Yeah, so it's not like Lego you take and put it together.
Yeah, I thought it's like you decide on it.
No, it's not like one big toolbox lah. It's each set. Like if you're doing a femur, it's a femur set, and they have components for that. If it's a distal fibula, they have their own. Yeah, it comes in sets.
Okay.
All right. Okay. So in conclusion.
Well done.
Yeah. Trauma is in general the core of orthopedic surgery, to be honest. Yeah. Every orthopedic surgeon knows how to deal with trauma no matter what. Diagnosis always starts with a thorough history and examination. Don't ever forget that. It's not about looking at x-rays. Examination, I can't stress enough, gives you a lot of information if done correctly. And acute setting management, always be aware of the physiology of the patient and the pathophysiology of trauma patients. So you have to be aware of the response, the patient's response to any acute trauma, whether it's their inflammatory status, their vascular status, you know. So that will help you in managing acute trauma. So in general, management of fractures, they require a good knowledge of fracture and healing patterns of each fracture, which in general is the science of orthopedics. Yeah, and applying this knowledge to each individual patient and making the right decision on the care of the fracture is generally the art of orthopedics. So if you know the art and the science of orthopedics, then pass lah.
Oh,
all right.
I think this was a very, very good and interesting and funny talk.
Okay.
A very good lecture indeed. I was very taken aback by the way that you have presented your knowledge to us. So the teaching was very good. I hope you all agree. Can you send in your questions now? We do have one question by Dr. Paul. He asked two questions, but they are not related to trauma or injury. He asked, what are your views on Chinese bone setters and chiropractors?
Okay, so Chinese bone setters, I don't have much experience with them. I don't know them too well. Chiropractors, chiropractors in a way, they have their own science. So they studied in a different way that we have compared to what medical and orthopedic do. So they have their own science, which is it has its own merit, I feel. I only say that because I have seen patients who actually do well after going to a chiropractor. You know, those who have chronic back pains and knee problems and all. So they have their merit in a way. But as an orthopedic surgeon, I cannot recommend that you go to a chiropractor, you get better, because I've seen patients get worse with chiropractors as well. You know, so their science is different. Their methods of learning are different. They've learned a completely different, you know, it's like learning English and Greek. It's two different languages, but they're both languages that allow you to communicate. So you can't say one is better than the other.
Okay, do you say science or do you say science? With the inverted comma.
No, science, I mean, you know, they study a different way. So if it works, it works. So normally, a lot of patients have actually asked me this, you know, can I go to the chiropractor? Will it be okay? So I said, like, most of the time I tell them, you can go, because I cannot tell you not to go because I don't understand what they do. They may be doing the right thing, but I also cannot recommend that you go. You know, so I can't recommend or restrict you from going in. I'm open to that, but not a lot of surgeons are. A lot of surgeons don't really like it.
Okay. Hi, Jenny. Jenny says, thank you for the lecture. It was amazing. She has a question.
Awesome.
For open fracture, you mentioned about soft tissue coverage after
Right.
wound debridement.
Sure.
Can you explain more about it?
Okay.
What if tissue is too bloody or destroyed? That is a very good question.
Sure. So in open fractures, yes, you have to base it on each case as you go along. Yeah. What happens is if you have too much soft tissue damage, you're going to have exposure of the bone no matter what. You cannot, especially in a tibia, which is a superficial sort of bone and there's not much skin surrounding, there's not much muscle surrounding the distal third and all that. So two ways to deal with that. One is either you consider doing some sort of a flap, a skin flap or a graft to cover it, or sometimes we even have to remove part of the bone so that there's enough soft tissue to cover the healthier part of the bone. So there are two options of doing that. Yeah.
So if you shorten you reduce the bone, you have shortening.
Sometimes you need to do that. Yeah, you do have. In some cases, you do have a bit of shortening, and then later you can actually lengthen it back. But commonly, you tend to find ways to provide the soft tissue cover. If at all you cannot, that means you don't have a facility to do a graft. You only have to debride. You have to remove a lot of soft tissue. What you can do is make sure that the dressing applied is always moist. So you use various moist type of dressings. In that case, you tend to preserve the bone, the livelihood of the bone. So in a moist environment, if you cannot get the cover initially, you can put a moist dressing. Eventually the granulation will start, and then you hope that you get the cover, and then you do the skin flap or skin graft or something over that.
So the bone can never heal with no soft tissue? No,
if it's exposed, it'll die. If you expose the bone, it look white on the first day, it start looking yellow on the next day, and then after it go brown and black.
I see.
It dies off.
Okay. Yeah. Luke has joined us before, right, Luke? So Luke says, hi to everyone, and an obese 34-year-old woman on Depo-Provera. I'm not sure what that is.
Can we? Gynae thing.
Oh, can we maybe Google that?
Must be some gynae. Is it?
It's recovering from surgery to fix an IM nail for a mid-shaft fracture of the femur she sustained while ice skating. What is the appropriate treatment to prevent thromboembolism?
Okay, again, thromboembolism commonly in acute trauma settings, you can give a subcutaneous sort of Clexane sort of.
Yeah, that's what he mentioned too.
Yeah, that would be the initial management for that. But I think the main thing when you have someone like this is to actually try to start them on early mobilization. The Depo-Provera is a contraceptive. Yeah. So yeah, it increases the risk of your DVT as well. The aim is always to get them mobilized early, no matter what medication you give, but you would cover them with some sort of a subcut heparin or low molecular weight heparin in this case. The tablet forms also are available now, but I wouldn't give for 42-year-olds at this point. Usually older patients who go for arthroplasty, you may need to cover them for a longer period of anti-thrombolytic sort of medication, anti-DVT medication.
Roshan, you can see the comments, right?
No, lah.
You cannot see the comments.
Where?
It's on the right-hand side.
Okay.
Can't see the comment. Okay, you go to the bottom of your you see chat. Do you see participant? Then you see chat.
Participant, yes.
Okay, then next to it is chat. You click on the chat.
Okay, hold on. I don't see the word chat though.
After participant, before share screen, there is chat. Anyway, Natia, I hope I pronounced your name properly.
Yeah, okay, I got it. Yeah. I found it now.
Say hello, doctor. Is open reduction only with external fixation?
No. Was that the question? Okay, sorry. What was the question again? Let me see it again.
Is open reduction only with external fixation?
No. The concept is different. Okay. Open reduction, close reduction is methods of reducing a fracture. That means bringing the two parts of the fracture together. Okay, so you do it open or close. Internal, external fixation is how you hold the fracture. So whether you're holding it internally with a metal implant or externally with an external fix or with a POP cast or with a splint or something. So the concept is two, yeah? You reduce it one way, either open or close, and you hold it some way, either internally or externally. It doesn't necessarily mean if you do open reduction, it's internal fixation, and if you do close, it's external, that kind of thing, yeah? But generally, if you do a close reduction, you're holding it from the outside. You're not holding anything inside the bone, inside the body anymore.
Okay, I hope that explains your question, Natia. So we have
Ligaments.
Danesha Naye saying, how long do ligaments take to heal? If the ligament is ruptured, can they?
It depends on which ligament. Right? Yeah, if ligaments are ruptured, like the anterior cruciate ligament, that one you tend to reconstruct it with something else. But if ligament injuries, you're talking about like ankle ligaments, or if you have a tendon sort of a repair done, in general, the rule is it takes about 6 weeks to heal. Yeah, it's a magic number in orthopedics. Everything takes about 6 weeks. I don't know why. So 5 is wrong, 7 is a wrong answer, 6 is a correct answer. Nothing more than 6.
So it's never 5 to 7 weeks. It's 6 weeks all the time.
Yeah. So I think I go back to Natia's question earlier. She put that can open reduction be done with external fixation? I think I didn't understand that just now. So yes, it can. If you do an open reduction, basically means that you're surgically seeing the bone, you approach the bone, you look at it, you put it together, and then you can apply an external fixator, like a metal external fixator, and hold it together. So yes, it can be done, open reduction with an external fixator.
No, she asked. That was the question. Oh, so okay. So it's not only with internal fixator, but can
if
be
you do
done
an open reduction, you can still use an external fixator to hold it.
Okay.
All right.
I think so. We have today. We had a very good attendance. We had 67, if I'm not mistaken. Of course, some dropped off. Those who came in late, don't worry. We got it recorded.
Except the beginning.
A bit late, but we got it recorded. And I'm going to share the recording in YouTube, and then I will share it with you guys later. And then we also hope that, Roshan, you don't mind us sharing the slides that you have.
Yeah, no problem. Yeah.
Yes, no, and then we will give you the file for the slides later. Sure. And next Tuesday, not Thursday, next Tuesday, we will then do some case study and some quizzes, also with Roshan and I, and we will try to set up this quiz like we did the last time when we did with Nisa. Okay, it was a very, very interesting lecture. I'm so happy.
Thank you.
Yes. I was very impressed. Thank you very much, everyone.
No, my pleasure.
I'll see you next week then. Bye.
All right. Thank you, Betty. Thank you, everyone. Bye-bye. Good night. Good night.
Bye-bye.